Thank you, everyone, for joining us. Can you see my screen or is this showing notes?
It's in the presentation mode, so
Okay, sorry about that. Hold on one second. Okay, sorry about that. Let's start over here. Hello, everybody. My name's Pam Bixby. Welcome. Thank you for coming to the second session of our research methodology webinar series. Our title today is the Randomized Registry-Based Controlled Trial, Low Cost, Big Impact. I'm Pam Bixby, Deputy Director of the Coalition for National Trauma Research, and it's my pleasure today to introduce our presenters. Well, the first thing I want to do is share. Oh, someone just told me she can't see my slides. Am I doing this wrong? I apologize. I got too many screens here, everybody. Once you show, all right, let's try this again. Now can you see my slides?
yes.
Okay, sorry about that. Our research methodology webinar series, we just started a few months ago. We will include this in our on-demand library, and the sessions you can get to our webpage via this QR code or this case-sensitive bit.ly address here. So everything will be archived there. If you miss it or if you want to share this with anybody, you can always go to our website to catch it later. Let me introduce our speakers very quickly. Unfortunately, Dr. Zarzar has had a travel emergency, so he is not joining us. Um, oh my gosh, you guys, I'm so sorry. I forgot the complexity of admitting people while trying to present. Um, so Dr. Guidry will present Dr. Zarzar's slides. He will give us an overview of the RRCT mechanism. And then from there, Dr. Cow, who is a professor of surgery and director of the Division of Acute Care Surgery at the McGovern Medical School at UT Health Houston, she's currently the president of the Surgical Infection Society. She is conducting an RRCT called Prevention of Trauma-Related Infections through an Embedded Clinical Trials Network, or the PROTECT Network. And her study is evaluating the comparative effectiveness of two pre-incisional prophylactic antibiotic regimens for the prevention of surgical site infections after trauma laparotomies. So she'll explain some of the details of her study and what is important to consider. And then Dr. Guidry, who's an associate professor of surgery and the acute care surgery research director at the University of Kansas Medical Center, he will present on he's the recipient of East's first RRCT award for his study, the study of trauma outcomes and with prophylaxis for ventilator-associated pneumonia, or STOP-VAP. And his study is seeking to determine the efficacy of a single dose of prophylactic ceftriaxone, ceftriaxone at reducing VAP-associated mortality in a general population of intubated patients. So enough of the introductions. I have muted you all for now. I will unmute you at the last 10 or 15 minutes of the session. You are certainly welcome to drop questions in the chat as well, or you can ask questions at the end. So without further ado, let me turn it over to Dr. Guidry for our introduction.
Thanks, everybody. It's really great to be here. Thank you for the opportunity to present what's going on with East and with Center, and as well as a little bit of information about the Stop App trial, which hopefully will start site recruitment pretty soon. I will warn you, I'm going to do a poor job of replacing Dr. Zarzar, but I do have his slides. If you see me looking down, I've got some notes and that kind of things to reference for his slides. But without further ado, I will share what he has. Let's see. And again, he apologizes for not being able to be here today. With some, all right, are you guys able to see?
I'm not seeing it, Dr.
Not
Guidry.
yet, no.
All right, let's see. Well, let's try again. How's that?
It's coming up now. Yep.
Yes.
All right, perfect. All right, so this is an overview of randomized, registry-based randomized clinical trials, RCT, particularly like East and Center's kind of version of it. So the working definition of an RCT is a pragmatic randomized trial that uses an existing clinical registry basically as the data collection mechanism. And that can be used for the platform of enrollment, randomization, data capture, and or other data outcome ascertainment. So basically, this can go all the way from a spectrum of a registry-supported study to a fully registry-embedded study. And in contrast with traditional randomized clinical trials and pure observational registry studies, these can be fairly pragmatic and efficient with accomplishing the goal of the clinical trial. So again, why bother? So the cost here is dramatically lower in general than doing a traditional randomized clinical trial, often at 10 to 20% of the cost of a traditional RCT. The speed at which you can do this is if you can leverage the registry quickly. I think that the term that I used whenever I was applying for this award was to be nimble, that you can react to things pretty quickly and then start cycling through some clinical trials fairly quickly because rapid enrollment is one of the key strengths of this design. Generalizability or pragmatism. This is happening in real world populations with fewer exclusions. And the pragmatic endpoints are usually already collected within the registry. There's some kind of landmark examples like the TASTE study, the Sweetheart study. We'll talk, and some trauma relevant analogs. We'll talk through one of the clinical trials here in a bit. And why is trauma uniquely suited to a registry-based randomized clinical trial? Basically, we have a mature, high-quality registry like TQIP. We have good quality state registries. We have good military registries. And there are equipoise on some common practices that have never really been randomized. And time-sensitive intervention, the time-sensitive nature of what we do, make it really difficult to proactively enroll in some of these patients, to enroll for some of these trials. So trauma, as most of you probably know, is the number one cause of death for everybody below the age of 46. Um, and it costs a lot of money, a significant $4.2 trillion of annual total trauma in the U.S. Statistical value of loss of life is that's 3,800 trillion. So it's a lot of, I don't know if that's a typo or not. That's a lot of money. Either way, trauma is very expensive, both in direct medical care and loss of quality of life, and then loss of work product later down the line. Despite being expensive and the leading cause of death for everybody under the age of 46, trauma is notoriously underfunded by the NIH. Actually, one of these talks and one of the things that Dr. Zarza or one of these points that Dr. Zarza wanted me to point out is that one of the part of the impetus for doing this through East and Center was to say, this part of traumatic injury not being well funded by the NIH, we tend to use as an excuse. And he references Dr. Wayne Meredith in his description of going through recent cancer treatment, and how he said every single step of what he went through was evaluated by a clinical trial. And every single thing he went through in cancer was guided by the outcome of some clinical trial that was related for that. And we just really don't, while we have good guidelines and we have good protocols and things in cancer and trauma, we don't have good randomized trials for a lot of what we do. Often we use this excuse of, trauma is not really well funded. And so part of Dr. Zarza's thought and from East and Center is, what if we stopped using that as an excuse and we came up with a mechanism by which we could do more clinical trials in our field that is outside of needing NIH funding? And this is East Center partnership that kind of came out of that. So here we go. So the we through part of this already. Sorry. So again, we can leverage the kind of the really high quality registries that we already have in trauma to accomplish a lot of these goals, right? So this example here is for like using myocardial infarction, where part of a patient has a hospital event, they're randomized to get either treatment A or treatment B, and then the quality registry is used to pick up do part of the data collection down the road. And these time sensitive interventions are kind of where this mechanism really shines. Some of the registry-based randomized control designs can use individual patient randomized designs. That's one of the studies we're going to talk about. This is what they did. The study that I'm doing, at least, is going to be a cluster randomized crossover design, which is the kind of this bottom section here. So you can have a parallel cluster RCT where you randomize different hospitals. So any cluster randomization is any randomization that happens at a level that's above individual patients. So we're enrolling patients, but we're not randomizing individual patients. So we're randomizing hospitals, clinics, ICUs. In my case, we're going to be randomizing trauma ICUs. So you can do a parallel cluster where you randomize them to two different treatment arms, and then they stay that way the whole time. We're going to, at least for the one that I'm going to be doing, we're going to be doing a cluster randomized crossover trial. So they're going to be randomized to a starting point, and then the hospitals, after a certain period of time, are going to cross over to the opposite arm. So each hospital participates in both of the protocols. And then lastly is a step wedge design where all of the hospitals start off in one protocol, and then they move into the other protocol in a stepped fashion. So they don't all move at the same time. So in this example here, in month 1, they're all doing the same thing. And then in month 2, only 3 of them are doing the same protocol, and 1 has started the new protocol. And then they add new sites with each new time block. Until eventually you get to a point where they're all doing the other protocol. That has some benefits with limiting your time bias and that kind of stuff. If we're going to keep admitting people. All right. Again, and this is what the East and Center Registry has chosen to focus on, is these cluster randomized designs, which are particularly well suited for a registry-based clinical trial. So again, a typical randomized clinical trial has a cost of about 17,000 patients, or 8.5 million for 500 patients. So these are a regular randomized clinical trial is very, 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 very expensive. So we're going to get into the example using the HPBA. So the America's Hepatopancreaticobiliary Association came up with a specific clinical trials committee formed specifically to do randomized clinical trials in their field, similar to what we're trying to do here with this East Center partnership. They collaborated with HPBA and the NSQIP, similar to the partnership we've created here. And what they came up with was looking at SSI, optimal SSI prophylaxis for patients who are getting Whipples. And then they picked between clinically accepted and FDA approved antibiotics. And this decreased regulatory hurdles and costs. And they enrolled 26 centers. They had 26 centers that enrolled patients. Now, this was done in cancer or in patients that needed Whipples, which are uncommon that they need to be done in an emergent fashion. So that one of the differences between what we're going to talk about in this example and what we will talk about later is they had plenty of time in general to enroll these patients, usually weeks ahead of time to enroll them in the clinical trial. But they enrolled 990 patients, and then 495 got Cefoxitin and 495 got Zosyn. And then of those 440 5 in each group were abstracted by NSQIP, which was their data collection mechanism. And then 50 of them were excluded due to unresectable disease. Again, these were cancer patients. So again, the ACS NSQIP pancreatectomy targeted module was their primary data collection mechanism, and then they had a few data points that they collected outside of the NSQIP registry, such as adverse events. This is the kind of one-page slide. So this was a high-impact study that was done very well and very cheaply and very effectively. And they showed that Zosyn had a significantly lower SSI rate than patients who had gotten cefoxitin. And this is now, at least at my hospital, this is the standard of care. The patients that are getting a pancreatic duodenectomy, they get Zosyn as their preoperative SSI prophylactic antibiotics. So for the request for proposals for this particular opportunity, it had to address ideally would address one of the top 10 questions from the NTRAP Delphi panels. That was a Delphi series of Delphi surveys that were done a few years ago, looking at trying to identify high impact, high yield research questions that are still pending within surgery. I'll admit that mine did not meet one of those, but we could be nimble and reach for a newer topic of interest, and I'll use based off of the ProfiVap study, which is what we're going to talk about with mine. None of the MTRAP high top 10 included anything infection related, and I have an infection related study. Mine was a medium priority, but it had to be a cluster randomized design. It had to use a single IRB. And then must use existing TQIP data points for the majority of the outcomes. So they proposed an East and Center panel review. East provided the Center with the funds, and then Center is providing administrative and regulatory oversight assistance. ACS TQIP is providing data management and site recruitment, and then statistical analysis is going to be paid for by the grant funding. And this is similar to how things are working for me right now. This was the timeline. This was initially pitched in June of 2024, and they announced the award in 2025. Those were all of his slides, and I think I stopped sharing.
All right, I'm going to now talk a little bit more about some nitty-gritty, and I will admit that I have some similar examples, so I'll try not to reiterate what Chris already said. So Chris alluded to the fact that registry randomized trials are really good for pragmatic trials. And so some of you have probably seen this before. This is the pragmatic explanatory continuum index summary. And what it is this wheel is a tool to help you decide how pragmatic your trial is. So a pragmatic trial is more real world, versus an explanatory trial is more like a pilot trial done in homogeneous patient populations with very rigorous set protocols and somewhat ideal circumstances. So the closer that your trial is to the outer portion of the wheel, the more pragmatic your trial. And so the point of all this is to say that these registry randomized trials are really designed ideally to answer pragmatic clinical questions. You don't want to use a registry randomized trial to test something that is a novel intervention for which you don't have any evidence, that isn't being used in the real world, and which may have very significant risks and harms. And some of that has to do with the way we do consent in these trials. So Chris already talked a little bit about randomization, and I would just say that the East Center proposal, as he mentioned, recommended cluster randomization. He mentioned that this NSQIP-based trial by the HPB Collaborative randomized patients on an individual patient level. One thing that I would say that if you were to design a registry embedded or registry trial using individual level randomization, something you need to be cautious about is something called Simpson's paradox. So if you don't stratify your randomization by center, when you look at the data of all the centers together, you might think that patients who got the treatment did way better than patients who got the control. But what might happen is at one center, you may have a significantly higher proportion of control patients. And for whatever reason, at that center, perhaps you have sicker patients or your resources are less, and so that your outcomes are worse. Whereas maybe you have another center where you have more patients disproportionately in the treatment arm who, and overall, your center does better. So when you look at the data by center, your treatment does worse than the control. So if you are going to do individual level randomization, you need to stratify by center. This doesn't apply for the East Center protocol. But another consideration, just to be complete, is the idea of contamination. And so a lot of times, if you're testing some sort of multifaceted intervention, uh, the providers, the nurses, the physicians may decide that the treatment makes sense or it's just easier for their workflow to continue to do one thing versus the other. So you get leakage of elements of the treatment to participants in the control arm. And so what that does is it causes any difference in outcome between the treatment and the control arms to be much smaller than they would normally be. That's because you're biasing your results towards the null. So again, not relevant for the East Center trial. Chris already mentioned parallel cluster randomized trials and cluster crossover. I'll just give you an example. This is not a registry randomized trial, but the same idea. This is something that one of our residents did a few years ago, where she wanted to compare usual care for assessing volume status in ICU patients to point of care ultrasound after admission to the ICU for trauma. And so what she did is she took the care team, which changed every month, and randomized them to either do point of care ultrasound in the first 2 weeks routinely or usual care in the first 2 weeks. And then the second 2 weeks of the month, they would switch over. And so each month it was random which one would start first. And the idea being that in theory, it's possible that if you start out with point of care ultrasound, that you would continue that throughout even if you were moving into the usual care arm. That didn't really happen, but nonetheless, this would be an example of a cluster crossover trial design. Chris mentioned the stepped wedge design. I would just say some of the reasons that you might pick a stepped wedge design are that, for one, every hospital or every unit gets the intervention. So if you think the intervention is useful or very likely to be beneficial and you actually want to implement it across all centers, by the end, all centers will have the intervention. So a stepped wedge is really good for that type of design. Versus, let's say, in an individual level randomized trial, only 50% of the patients get the intervention. Additionally, stepped wedge designs are nice for complex interventions. So let's say you are testing like enhanced recovery, which is a multi-component intervention across multiple hospitals. By having a stepped wedge design, you give each hospital a period of time where they can implement the intervention. So that if, for example, you're doing a trial across multiple units in your hospital, you can focus on the implementation in each unit and you don't have to worry about doing it all at one time. So this is an example of a stepped wedge cluster registry randomized trial. This is from Gretchen Schwarze at University of Wisconsin. So she randomized centers to either use the best case, worst case ICU scenario to communicate with patients and their families versus usual communication. And so you can see here, she had 6 different quarters, and hospitals were randomized to to which quarter they would implement the intervention. And you can see that there's very deliberate phases for implementation, so that there was time set aside to actually have trained the hospitals and the physicians there on how to use the tool. The other thing she did was she stratified based on very high or high volume hospitals. So instead of randomizing the hospital to what intervention they're getting, as mentioned, they're randomizing the hospital to which time period they're going to get the intervention. And although the figure makes it look like hospital one starts with control and then moves to the intervention, in reality, in a stepped wedge, the hospitals may not be in that particular order. The implementation isn't necessarily sequential like that. All right, one thing that you need to be careful with when you're doing a cluster randomized trial is the intra-cluster correlation. So the idea that patients within one hospital are more similar to each other than to patients at another hospital. And so if there's variation across the hospitals, whereby, again, like in the first row here, it probably doesn't matter which hospital you're at. There's a wide variation in the outcomes between the different hospitals. But in the high ICC hospitals, you can see that patients are kind of grouped together and are more similar to other patients in their own hospital than they are to patients in other hospitals. So you need to adjust for that. So there's some statistical considerations, and I'm not going to go through the. There's a lot of statistical considerations also for stepped wedge designs, and you would probably want to consult a statistician. All right, I'm going to talk briefly about consent strategies. So, in a traditional informed consent model, like the trial that tested antibiotics in Whipple patients, you would get informed consent. Patients who consent would then be randomized, and then they would get the intervention or the control. There are opt-out designs. So typically, the traditional design is you ask patients to opt into a trial, but you can ask patients, you can just assume all patients will be in the trial and give them an opportunity to decline. It's really just reframing it. And there's some data that suggests that an opt-out consent may be more successful in having a higher enrollment rate, and is sometimes used in cluster trials. Now, you can also have something called delayed consent, and this is typically for pragmatic trials and can go with sort of an initial waiver model, and we'll talk a little bit about that in a second. So, in a delayed consent model, you randomize patients and you provide the intervention, and then you get consent later. So I think one area that might be confusing to folks would be the difference between exemption from informed consent or EFIC, which is obviously common in trauma studies, or versus waiver of consent. So in an EFIC trial, typically those are done for life-threatening emergency conditions. So for traumatic hemorrhagic shock, if you're testing two different resuscitation strategies, you're not going to be able to get consent. It's not feasible. And if it's not clear that one treatment is superior to another, and there's scientific necessity to do a trial to figure out which one is better, then you might get EFIC. There is potential for direct benefit, and the risks and benefits overall have to be acceptable to patients. And so in EFIC, you have to do community consultation, and there's a whole process before you can get EFIC for your trial. Now, that's different from the idea of waiver of consent. So I'll give you an example of a trial that has waiver of consent where you don't necessarily have to be testing an intervention in a high-risk emergency condition, but rather we're talking more about comparative effectiveness trials. So say, for example, there are two interventions that are widely used in clinical practice, and really it just depends which physician you get, or maybe there's no real pattern to who gets treatment A versus treatment B. So in a waiver of consent trial, there's minimal risk. It's not practical to do the trial without the waiver, and the rights and the welfare of the patients are unaffected. A lot of times IRBs will request that patients then receive a post hoc disclosure if it's feasible that they were in a trial. And so I'll give you an example of a trial and the rationale that was used. This was not a registry randomized trial, but In the trial that I'm doing of two different antibiotic regimens for trauma laparotomy, it uses the same justification. So the idea would be that, so this trial was testing two different antibiotic regimens for suspected gram-negative sepsis. And so it looked at, I believe, piperacillin tazobactam versus cefepime. And so the rationale was that both antibiotic regimens are part of routine care. Patients would be exposed to one or the other antibiotic, even if they weren't in the trial. There wasn't any prior high quality data to say one was better than the other. And the options were equivalent from the perspective of the treating provider. And so this was the rationale, and this trial was performed with waiver of consent and published in JAMA. In my own institution, when we teach ethics as part of our master's degree program for clinical research, we talk about these 2 points that are listed here. One is that we use unproven therapies in clinical practice all the time, but we don't always get consent for them. So it seems a bit like there's a double standard for saying we're going to get informed consent if we use an unproven therapy in clinical research versus clinical practice. Now, I did say that in a registry randomized trial, we're not really testing unproven therapies, so this argument doesn't quite hold here. But also the risk of unproven therapy, and perhaps I'm using unproven more to mean that there's no data to demonstrate one therapy is better than another. It's not greater in clinical research than clinical practice. If anything, there are greater safeguards when you're doing a clinical trial with the Data Safety Monitoring Board, et cetera. And then one last thing about consent, or actually I have a few more points about consent, is that interestingly, even though you may get waiver of consent for the intervention, sometimes you then have to get consent for data collection. So we've actually had scenarios where we had a waiver of consent to test two interventions that are widely used in clinical practice. But then because we were collecting additional data that is not, let's say, part of the registry, or that requires follow-up of the patient and therefore identifying the patient and calling them later, there may need to be consent for the data collection. And so, especially if you're adding on to TQIP or the registry data. I just give you one last example of how consent can be complicated. So when I think of the first trial, which tested, as you know, flexible duty hours versus standard duty hours, this was in fact a registry randomized trial. And so if you think about it, though, there were three different sort of levels at which the trial was testing an intervention, right? So who or what unit was randomized? Well, residency programs were the cluster. So it was a cluster randomized trial. But who was intervened upon was actually the residents, and then indirectly patients, if you believe that the different duty hours had the potential to impact patient care. And then whose data was used was actually the patient's data from ACS NISQIP looking at post-op complications. And if you all may recall, there was some controversy around the ethics of the trial, and I won't go into all that, but just to demonstrate that these types of trials can be complex in terms of having different layers. All right, just briefly talking about data consideration. So when we think about registries, because you can do registry randomized trials with databases other than just NISQIP or TQIP, but you need to think about these four different buckets. One is how relevant is the registry to what you're studying? How good is the data collection? What are the legal and ethical considerations? And what are the practical components in terms of operations and infrastructure? And you can see here that this is a proposed framework for what characteristics are necessary for a registry randomized trial. And again, it kind of boils down to these four buckets. Is the data in the registry the right data to answer the question that you're asking? Is there a data management plan? How do you know that the data is accurate, that it's timely, that that it's being adjudicated appropriately? What is the governance in place? And then is the registry adequately resourced and financed? And this slide with key performance indicators pretty much says the same thing. I just give you an example back to the best case, worst case ICU registry randomized trial. So it used TQIP And you can see here it collected all the patient demographics, clinical data, and outcome data from TQIP. The ACS created what was called an incremental data collection platform to add in one additional data point, which was vital status at 6 months. The investigators added a quality data check where you would enter ICU length of stay to see if it correlated. And then they chose actually not to link their primary outcome, which was a caregiver survey, to the actual TQIP patient data. But it is possible in your registry randomized trial that you may want to link TQIP or other registry data to other databases. So again, you can see that there may be multiple considerations when thinking about what data you're going to use. And then I'll just end with a checklist. So if you decide that a registry randomized controlled trial is the right design for you, again, or how do you decide? So is the clinical question a good scientific fit? Meaning there's no high quality evidence. Is there equipoise? Is it a true comparative effectiveness trial where the interventions are routinely in clinical use? Is there potential for practice changing impact? And will the intervention integrate into the workflow easily? We already talked about the data requirements. It is important to figure out how you're going to manage the consent. The Center East trial asked for a single IRB, so there are clearly benefits to having a single IRB that provides approval, and then the other institutional IRBs go off of that approval, and then you're going to need some data use agreements. And then, I didn't mention a lot of these operational feasibility points, but figuring out how to randomize patients. Are you going to embed the point of care randomization into the registry? How do you get stakeholder buy-in? How do you make sure that each center is doing the intervention as intended, although in a pragmatic trial, you don't have that tight of a control because it's very real world, and then figuring out funding. So I will turn it back over to Chris to talk about his trial, and we can answer questions at the end.
All right. Can you guys see my slides? Perfect. All right. So, first step to any good trial is you need a good name. I think I've got a good name for this one. All right. So we're going to call it STOP-APP, Study of Trauma Outcomes of Prophylaxis for Ventilator-Associated Pneumonia. So my disclosures are that I did receive the East Center RCT award. And secondly, this is my approach for the problems and challenges and opportunities that are posed by a registry-based clinical trial. This is not the only viable option. This is not the only solution. But this is my example of kind of how I'm approaching this mechanism. So this is the study that kind of prompted STOP-APP. So this is Prophy-VAP. So this is ceftriaxone to prevent early ventilator-associated pneumonia in patients with acute brain injury. This is a multi-center randomized, double-blind, placebo-controlled, assessor-masked superiority trial. This was a very, 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 very highly regulated clinical trial. And they ended up enrolling a few hundred patients. This was a very, very expensive trial to run. They did one-to-one randomization, double-blind, placebo-controlled, assessor-masked, superior. All of those things cost money. They use intubated patients with acute brain injury, which really is a lot of patients who had strokes, and a small number of patients had TBI. And then they looked at 2 grams of ceftriaxone within 12 hours of intubation, the exact same intervention that we're going to be looking at for this study. And their primary outcome, importantly, was just early VAP, which they defined as within 7 days of intubation. So again, they enrolled about 162 in the ceftriaxone group, 157 in the other. They had an 18% reduction in early VAP. There's a saying for people who look at study pneumonia that people tend to die with pneumonia rather than from pneumonia. It's unclear whether these are a lot of like aspirations. It's unclear the real clinical relevance. But what's odd is that they found a 10% reduction in mortality at 28 days, which is a little That's bananas. Okay. So is in trauma and in surgery, we give single doses of antibiotics for lots of things, like putting in a chest tube, putting in, going to the operating room, and we don't anticipate a 10% reduction in mortality based off of that. But the quality and the rigor with which the study was conducted um, mean that you really have to pay a lot of attention to this outcome. In terms of equipoise and that kind of stuff, I happen to know somebody who's not a trauma surgeon, but works at one of the hospitals in France that did this study. And I asked her, like, hey, are your people giving ceftriaxone? And that answer was no, they are not. So there are some other trials, the Antarctic and Sudoku, that have evaluated prophylactic antibiotics in intubated patients. This is a well-trod area. Most of these have small sample sizes, other than Sudoku, which had about 5,900. But overall, a very, very, very small number of trauma patients, 86 to 129. So that 129 was the total number of trauma patients in Sudoku, even though it had 5,900 people. None of these are powered for mortality. So none of them answer the question of like, do we need to be giving this antibiotic for patients who are to reduce their mortality? So here are the aims for Stop VAP. So the specific aim one is we're going to do a confirmatory clinical trial, which does not happen very often, but I'm excited that we're going to be doing one here. So we're going to confirm the findings of the ProfiVAP study and determine the efficacy of the single-dose prophylactic antibiotic at reducing VAP-associated mortality in a general population of trauma patients who are intubated prior to or upon arrival. And our hypothesis is that for a general population of intubated trauma patients, prophylactic ceftriaxone will be superior to no intervention with respect to all-cause inpatient mortality. If you take care of trauma patients, you know that like for open fractures and other things, we give a lot of other antibiotics. And so our exploratory study, and by exploratory, what I really mean is that we're not going to be powering the study for this outcome, is that we're going to determine the impact of other commonly prescribed prophylactic antibiotics on both VAP rates and inpatient mortality in a general population, the same population of patients. And our hypothesis is that we'll be able to identify some commonly prescribed antibiotics, and we can kind of probably guess what they were, that'll confer a similar reduction in VAP rates and therefore kind of avoid double dosing these patients. So again, Stop VAP is going to be pragmatic. I am very interested in real world applications for studies. Multi-center cluster randomized, we're going to be randomizing at the level of the ICU. The crossover, in which case, meaning that that every hospital is going to participate in both arms of the study. They'll just be randomized as to which one they start with. And this is going to be a superiority trial, which meaning is related to how we are powering the study. Our inclusion criteria, they're going to be all adults 18 years or older who are intubated in the field or in the trauma bay and who survive for at least 48 hours. And we can do this. I don't have to say expected to survive. I'm going to say survived, because the patients are going to be getting the intervention in real time, hopefully very soon within time for intubation. But we're going to be identifying these patients later in a retrospective manner using the registry. Our exclusion criteria, going to be known allergy to ceftriaxone or cephalosporins, or if it was an interfacility transfer. So again, in terms of pragmatism and feasibility, easy inclusion and exclusion criteria so that it's very easy to apply the protocol in real time. And the intervention is going to be a single dose of ceftriaxone, and the control arm will be no antibiotics provided specifically for VAP prevention. So if there are other another reason for antibiotics, those are going to be perfectly fine. Our primary outcome is all-cause inpatient mortality. This will be what the study is powered for, and we have secondary outcomes like VAP-related mortality, VAP rates, overall total days of antibiotic, lengths of stay, protocol compliance, things of that nature. So our VAP sample size, we're going to power this for a 10% reduction in mortality. So we're going to power it for the exact same finding that they saw in the ProfiVAP study. Would a smaller reduction in mortality be clinically meaningful? Absolutely. However, you will see what the sample size is going to turn out as. Cluster randomization tends to balloon your sample size, and so ours is quite large. And so feasibly. That's about the lowest that we can get. One thing that you do need to do is that you need to have an estimate of your interclass correlation coefficient. I have done a cluster randomized clinical trial in trauma, mostly trauma patients in ICUs. And so we were able to use that as and measure the interclass correlation coefficient, which is how similar are these patients within the same cluster. And then you also need the between period correlation coefficient, which are how similar patients within the same cluster at different time periods. So in protocol A versus protocol B. Um, and so you need both of those. The effect of both of these is that this is going to significantly inflate the sample size, such that we're going to enroll almost 12,000 patients. So 12,000 patients will provide 80% power to detect a 10% reduction at a 0.05 alpha or significant level. There is a calculation that I don't know, but my biostats guy does, for the optimum number of sites needed for a cluster randomized clinical trial. You can imagine that if you keep adding sites, you reach a point where the benefit you get from the increased number of patients is overshadowed by the increased variance you get by adding a new site. So there is an optimum number of sites, and in our case, it's going to be 17. And so while this sounds like a whole lot of patients, really we're going to be targeting high volume centers, and we need to average a patient a site per day. So at your trauma center, can you imagine intubating or having one intubated patient a day come in? If so, then we're going to be able to get this done. So one patient per site per day on average is what we need to get our goal. Our timeline is that we're going to run each arm for a year, and then we're going to cross over. We are not going to do a formal interim analysis. If you can imagine, if we do an interim analysis before they've crossed over, we actually have a biased sample. And so any findings that we find could be related to the natural mix of patients across those sites. And it just happens to be that some of the sites with a higher higher index or higher mortality rate happen to be randomized to one arm versus the other. The benefit of the crossover is that all of these sites get to serve as their own internal controls. And so we're not going to be doing a formal interim analysis. And we're going to start safety and enrollment checks 6 months after the start. And the reason for that is concurrency, which I'm going to get at. We are going to add some variables to the data collection mechanism. They are related to things that we need for, like, this is a intubated patients with pneumonia. This is in the realm of a sepsis-y kind of thing. And so we need to be able to calculate SOFA scores and highest temperature, COVID-19, that kind of stuff, some other antibiotic things. We give a lot of antibiotics, prophylactic antibiotics in trauma bay and for patients who are going to surgery and things like that. And so while we collect yes, no, did they get prophylactic antibiotics in the TDB, we don't know what they are, so we need to ask what those questions are. It's also helpful to know what pathogens we're seeing at the end, and so we're adding the pathogens at the end. But the primary outcomes of all-cause inpatient mortality, ventilator-associated pneumonia, things like that, are already well represented within the TQIP and NTDB. So one thing that I did want to touch on is concurrency. So this is a cluster randomized trial. Didn't mention it previously, but we do have a full waiver of consent for this. And our IRB is approved. The patients are going to be getting the intervention in real time, but we're not going to know who they are necessarily. The registry won't know who they are in real time. So there's a lag. How many percent are you done within so many months? That concurrency rate is variable from site to site. And so that has a real impact on your enrollment estimations, on when you're going to be doing your safety reporting, how you time an interim analysis if you were going to be doing one. We have chosen to wait for about 6 months before we start sending these, do our safety checks and our enrollment checks. Hopefully, so that then we have at least 3 months worth of completed data, and then another 3-month period where we're going to have some variance of concurrency within there, and then at the end of it, and eventually we'll be going there, have good data. But that concurrency lag is something that we're trying to account for in planning the study in the first place. Um, so no good plan, no good battle plan survives first contact with the enemy. And so I will say that everything has taken a bit longer than expected. Getting the study started up between agreements between center and east in my institution took a bit longer. The Once I had the ability to pay people, then only then could I start on the IRB, which went okay. And then we're still dealing with some contract issues with the ACS. Some of that is just because my facility has been slow for reasons that are outside of my control. But we do have central IRB approval. The ACS contract is pending, but should be finished soon. We'll be starting site recruitment, looking for high volume centers to participate in the study. That is, I think, all that I have, and I'm happy to answer any questions. I will stop sharing my slides.
I see that Bavin is on from the ACS. Did you want to say anything? Oh, did he just sign off?
No, I'm here.
Oh, okay.
That's a great summary. Yeah, we should have some updates soon on that contract. It's with our legal department right now.
Yes.
Great summary though.
I meant if you had any comments in general from
Oh,
the ACS standpoint,
no.
not about Chris's contract, about registry randomized trials and
Oh.
facilitating them through TQIP.
Yeah, so our research registry product, as you know, Dr. Gretchen Swarzy was kind of the first external researcher to use it. Now Dr. Chris Guidry was the second. We're hoping this is another mechanism on how we can accomplish trauma research going forward using the TQIP platform, but also getting these custom variables in there that are vital for these clinical trials.
Although I do appreciate the update. I will say for the record that Mr. Patel and folks over at the ACS have been really, really great to work with. Very easy.
And we are going to move forward with the antibiotic one. That just everything's slower than than planned, as Chris said.
I see a question from Malik Harfouche.
Yes, hi. Chris, thank you so much for telling us about your trial. I had some questions. One is, how will the sites be running the intervention? How will they be identifying, well, I guess it's any patient who's intubated or will be intubated, but are you going to be paying sites to have these researchers? Because I know that adds a lot to cost of these clinical trials, is the kind of the 24/7 monitoring in the trauma bay to assess for eligibility. How will the funding work for that?
Great question. We are while East is very generous, we are broke. So I do not have a dime to give the others any sites. So the breakdown of how the money is being sent is about a third for the IRB, which I had to negotiate down. About a third for biostatistics, and a third for the ACS, roughly. So while there is a little bit of wiggle room, it's in the couple of thousands of dollars, and so I don't have the funds to be able to pay the sites. So but with the design, we don't need 24/7 researchers in the trauma bay. So there will be an onboarding process where we go through and talk about the protocol. The inclusion/exclusion criteria are, as I mentioned earlier, really, really easy to remember. We'll have some signage available for the participating sites that can put in their trauma bay if anybody has any questions or issues or to put in their ICU. So it's really just, are you intubated and have you lived for, are you intubated and, do you anticipate to be alive in the next 48 hours? The patients on the back end will be identified by the time period in which they were enrolled. So the registrars will know which group that they were in, and then whether or not they got whether or not they got the intervention or not, which is we're recording whether or not they got ceftriaxone. So we're leveraging the data collection mechanisms that are already required to be in place by virtue of being a level 1 trauma center. So we shouldn't need 24/7 researchers, and there won't be any money to pay the sites, unfortunately. But yeah, I don't know if that answers your question specific.
I got it.
Yeah.
So each site will be a specific time frame where they prophylactically give the antibiotics, and then
Yep.
they'll adjust their process to not give the antibiotics
Correct.
as a site, basically.
So let's say that your center and you're participating in the study. You'll be randomized. All of the 17 sites will be randomized as to which arm of the study they start with, either giving the ceftriaxone or not giving the ceftriaxone. And then you'll do that for a year. After the year, then you'll cross over to whatever the opposite arm is. So if you weren't giving the ceftriaxone, then you'll start giving it. And if you were giving it, then you'll stop.
Got it.
And I don't anticipate perfect compliance. But,
And some
And how did you-
crossover trials, crossover more than once. So like it could be, rather than just crossing over once, you could say each month you're randomized to one versus the other. And it depends month to month, but that requires a little bit more coordination.
yeah, that's a bit more coordination and more opportunities. I thought for at least for this one, more opportunities for to mess it up. So I thought if we kept it going for a year, it would be easier for on all of the team members who are providing the clinical care to remember. There was a question about matching. Correct, there will not be any direct matching apart from the randomization that happens at the cluster level.
And did you see the next question, Dr. Guidry? Limiting the study to large volume centers.
For some reason that was not showing up. Why am I limiting it to large volume centers?
I'm curious about your thoughts, limiting the study to large volume centers and the cross applicability to smaller centers, more rural hospitals.
Yep, I just need to get the sample. I need to make sure that I get the patients. That's the reason for starting with high volume centers, is I need to make sure that the study enrolls. And so in my thinking, a higher volume center is a higher likelihood of having somebody that's going to meet those low but not non-existent eligibility criteria, and to be able to get at least one patient per day. And that's the only real thought. So
I would just say one of the pragmatic things about doing these trials is that the more data elements that you add, the more sort of resources you need to go back to the chart to find the extra elements. And so even something like, looking at 2 antibiotic regimens for SSIs, TQIP, unlike NISQIP, doesn't look at 30-day outcomes. So you have to pick a question that can be answered using in-hospital data, or you have to do some sort of chart review to see if the patient came back to your hospital within 30 days or contact them. So the more sort of additives that you have, then you still need some resources. So that may also sort of indicate what kinds of centers you can enroll in your trial. So even though it's less work than a completely non-registry-based trial, there's still some component.
Question about, is Profivat study published? Yes, that was published in the Lancet, I don't know, a year and a half ago, 2 years ago, something like that.
Well, we are at time, Dr. Guidry and Dr. Cow. Thank you so much for providing us this education. As I said earlier, this will be on our website. I will send out a notice to everybody, and please feel free to share it with your colleagues. Thank you. Have a good evening.
Thank you so much.
Thank you.
Thanks.